One of the biggest myths in leadership is that you have to have some sort of title or some sort of rank or some sort of status in order to exercise leadership. And we're trying to dispel that because it's a myth. If you think of leadership broadly as an activity that moves the organization forward in such a way that we better serve the people that we're intending to serve, be it patients or students or faculty, really anybody and everybody can contribute to that purpose. And we were down in Peru last week and we met with a small group of women, Los Visionarios, who have exercised superior leadership in Peru. These are women who have few, if any, resources, no particular authority, yet by coming together to form a group to help the poorest and least fortunate of the Peruvian people, they've helped organize communities who work together. They're working on providing better access to health care in the country. For me, it was a great example of people leading effectively without any kind of title or formal authority. You know, if you take our own medical students here at Geisel, the very large proportion of our students participate in some sort of community service project. And were you to go through those projects, the leadership that they're exercising collectively in terms of providing good to the community, volunteering to see patients, working to provide services that uninsured patients don't have. It's really an enormously inspiring example of individuals, in this case our students, who come together with no formal authority, no power per se, yet are contributing in a way that is moving the medical school forward, in that we're here to improve the lives of the people we serve. Leadership and management, they're both critical activities in any organization. They're different activities, but they must be complementary for the organization to be successful. So we think of leadership as about setting direction for the organization, about building the right team of people that are going to help move the organization forward, and about creating the right culture. You need the right people to create the right culture. And here at Geisel, we've been pretty explicit about the kind of culture that we want to build together. It's a culture that is anchored in a set of values and behaviors, which include teamwork and excellence, open communication. There is a tendency to think that leadership and management are that they conflict with one another, and to some extent they do. So if we think of leadership as about setting direction, building the right team with the right people, and creating the right culture, management is more execution oriented. It's about standardizing, it's about organizing, it's about being on time and on budget, if you will. You know, if you take the operating room here at Dartmouth Hitchcock, where we perform hundreds of operations every week, we want to perform the same operation, be it a colon resection or a orthopedic procedure. We want to perform the same operations to the extent possible in the same way every time, and that's called standardization. We know when we standardize, we eliminate the likelihood of mistakes, we increase efficiency. Those are managerial activities, and they're absolutely critical. What I find interesting is that leadership really is about producing constructive change. It's about moving an organization forward into a better place. Again, that better place being such that the organization better serves the people it's designed to serve, better improves the lives of the people it serves. Management, on the other hand, is in a very real sense about not changing. It's about doing things the same way to get better results. So one of the inherent tensions that we live inside is this sort of change versus no change. And the way that shows up as we create the future is we want to bring the best of the past forward, but make the necessary changes to improve effectiveness as we go forward. This notion that leadership is future-oriented is an interesting one. If you look inside of your own life as a human being, you'll see that you're always living into a future. Now, what do we mean by that? Well, you know, the future that you and I are living into is a future that presumes that we'll be around next week. It's a future that presumes that we'll continue to educate students and conduct top-notch research and provide world-class patient care. The language we use is we say the future is the context for the present. So although we're living into a future, our actual actions and our behaviors occur today in the moment. Now, why is it important to be clear about that? Well, if you're living into a future which is one that shows up for you as hopeless or as gloomy, that's going to powerfully shape and impact your way of being and your actions in the present. And unfortunately, that's the kind of future that many of our underserved populations in healthcare live into. So we're trying to make a difference by changing that. The future that we're trying to articulate here at the medical center is one where the students and the physicians and the patients can see that future as positive. You know, for the students, that means that that their education is top-notch, that they imagine themselves to be well prepared to take care of patients when they graduate and move into residency. For the physicians, and this is a particularly complex one with all the changes in healthcare, it's envisioning a future where they can continue to be agents of care for their patients, and where they see a healthcare system that continues to allow them to provide that top care. And of course, for patients, it means a healthcare system that provides access that is of high quality and that is affordable. So one of the important things that we're trying to do here is to articulate or a future, or you could say a vision, that people can get excited about. One way to get people excited about the future is for them to be able to see in that future their own hopes and aspirations realizable, or you could say achievable, and we think there's plenty of room for that. We think that we're up to some good here, that the future we're committed to creating is a bold future, it's an exciting future, it's one that people can get really excited about. And if you can find that for yourself in that future, then you're going to tend to own it. And what that means is that in building that future, if you've got a stake in it, that you're going to be willing to overcome the various obstacles and breakdowns and barriers that are invariably going to show up along the way. I mean, the future is only a possibility, and the future we're committed to creating is a big future. So, not surprisingly, we know that it's not going to be a cakewalk, so to speak. So we want everybody to be committed to that future, so that their ways of being in action in the moment will help create it. So this notion that leadership begins as an inward journey is one that we're trying to have our students and residents and faculty be cognizant about. Now, what does that mean? Yeah, I'm a strong believer that you cannot lead effectively out here. You can't effectively lead other people. You can't effectively move an organization forward unless you're pretty grounded on the inside. And that's the so-called inward journey of leadership. And it's a process of inward thinking, so to speak, and involves some degree of introspection. And it begins with acknowledging that we all have certain ways of being, certain behaviors that can get in the way of our effective leadership. So in my own case, for example, I am aware that I can get impatient when things aren't going as quickly as I'd like them to do. It's just one of the ways I wound up being. I tend to be impatient. So if I'm aware of that in a conversation with the students or in a conversation with the faculty, if I'm aware that there's a listening going on up here that gives me an inclination to be impatient, just the awareness of it tends to relieve me of it. It doesn't control me as much. So that's one of the elements of sort of leading from the inside out. You know, another one is that, you know, we've all got these, you could call them strategies, if you will, that we go to when we get stressed. You know, and there are plenty of difficult circumstances we're dealing with in healthcare that could raise the temperature and the pressure in your pressure cooker, so to speak. And being aware that you have a tendency to do this is this whole self-awareness notion, which is so important. Another notion of this leading from the inside out is that's been an important distinction for me over the years, is this notion that you have to be a leader first. There's so much emphasis in leadership on knowing and doing and getting results, and I would be the first to say that those things are important. But one of the messages that we're developing at Dartmouth is this notion that unless you're being a leader first, it's impossible to act like a leader. Now, what does that mean? You know, we believe that the foundations of being an effective leader reside with 3 or 4 important, we call them pillars. So one of them is integrity. And when we use the word integrity, we recognize that it has implications for character and honesty. But another very important way of thinking about integrity is derived from the root of the word integer, which means whole. We talk about whole numbers and integers and the like. When a system is whole, it works extremely well. And the way that human beings live inside of integrity is to keep their word. Your word is what keeps you whole. And so, you know, we're very clear that you want to be thoughtful about the promises that you make, and don't make a promise that you can't keep. And if you can't keep your promise, and none of us keeps our promises all the time, you want to honor your word. And you do that by letting whoever you gave your word to know that you have to break your word, and then you help them clean up any mess or whatever that you created by having to break your word. A second one, which we've talked a lot about in the medical school in administration, is this notion of authenticity. You know, what does it mean to be an authentic human being? And essentially, it means showing up for other people, and for yourself, for that matter, the way you say you're going to show up. So if you claim to be a team player, you want people to experience you as a team player. If you claim to be someone who's willing to go out of your way for your patients, you need to show up that way for your patients. one of the most frustrating aspects of being cared for as a patient is having your physician tell you that they will do this, and then it's not done. Again, that gets a bit into the integrity piece. The third, which we think is critically important, is this notion of self-awareness that we talked about before, and just being aware that all of us bring a set of biases and assumptions to the table in any conversation that we have. The act of being aware of that can be quite liberating. And then the fourth is commitment, and commitment fits with this notion of creating a future. Pretty hard to create a future if you're not committed to. And the language that we like to use is you need to be committed to a future that's bigger than you are. And if you search inside of your own life, you can find examples of where the future that you were ostensibly committed to was really no bigger than yourself. I went through that myself a number of years ago when I got clear that my desire to build my resume, my curriculum vitae, was really kind of just about me, and that wasn't a very powerful commitment. When you can get committed to the students or to the patients, that's a future that's bigger than any one person. That's the kind of future people can line up behind, put energy behind, and move an organization forward. One of the unique things about human beings is that we have language, and there are clearly other species that have elements of language, but our language is by far and away the most sophisticated in our ability to communicate, to listen, and I think one of the most interesting things about our command of languages is, best we know, we're the only species that can talk to ourselves. So just, again, try it on, check it out in your own life, and you'll find that the world that shows up for you, that's the language we use, the world that occurs for you is largely a world that is constituted, you could say, constructed, generated in language. So look around wherever you are, you may see trees, you may see tables, you may see chairs. Whatever you see, your understanding of what you observe, of what you perceive, will live inside of language. What we mean by a conversational domain is a series of often specialized terms that are linked together in a sentence in such a way that they give the user of that language access to a domain that a person who was not proficient or a master of that language would have no access to. Let me give you an example. There is a language of medicine. Our students have to become quite proficient with it over the course of their 4 years. And that language of medicine uses words that lay people have never heard of. And by mastering those words and the way that they're assembled in a sentence, that gives the students and the doctors that they become, it gives them access to the patient. It gives them access to the patient's body. So when they examine the patient and listen to the heart, they may detect a murmur that someone who didn't have that kind of access wouldn't detect. It gives them access to the patient's history, their social history. It gives them access to the patient's illness. It can even give them access to the patient's suffering. We could say the same thing about the language of engineering. If you don't know the language of engineering, it's pretty difficult to get access to that realm of study or to that domain. So we want our students to become masters of the conversational domain of medicine. I think that probably doesn't happen in 4 years, although they approach proficiency. But by the time they get through residency and begin to practice, usually 8 to 10 years, they achieve mastery. One of the interesting things about achieving mastery is in the process of exercising your mastery, or being an expert, you could say, you use the language that is pertinent to your domain. But one of the curious things that happens is the language also starts to use you. Where you see this, for example, is when you go to the emergency room and there's a trauma victim, and you observe the trauma surgeon exercising her skills and her management of the patient. It's second nature. She doesn't have to sit down and think about every step of what I do next. It just kind of naturally happens as her natural self expression. We put great emphasis at the Geisel School of Medicine on developing our students who are culturally competent. That's a bit of a challenge for us because of the demographics of New Hampshire. So we've gone out of our way to create experiences for our students to spend time in the southern part of the state, which is a more diverse community. We have a wonderful program in San Francisco with the California Pacific Medical Center, where our students get to participate in the care of a much more diverse group of patients. The reason that's important is because, building on what we said before, the way people experience the world is a function of their language, but also a function of their culture. And so it's critically important for our physicians to have a good sense of, where is this patient from a cultural standpoint, from the world they live in, from their preferences, where are they coming from? And while you can never really put yourselves in somebody else's shoes, that kind of sensitivity, that kind of empathy is absolutely critical. You can read that stuff in a book, but at the end of the day, you can't master it from a book. You've got to master it by being present with patients who have very different backgrounds, different ideas. This sort of diversity of thought is absolutely critical. So we're committed to creating that kind of experience. This has enormous implications for the way that our students learn to listen to their patients. And I believe that listening is a skill that has been dramatically underemphasized in the whole field of healthcare. The emphasis tends to be in the communication realm on speaking, but listening is critical. And this is something everybody can practice. What we tell our students is that when you're with a patient in the exam room, often one-on-one, you've got to listen to them generously, is often the word we use, and you have to practice that listening. And what you want to be able to do is to reproduce to the extent possible over where you are what is being said over there by the patient. And that takes some practice. If you learn how to do that through practice, where you can reproduce where you are what the patient is saying, that's going to dramatically shape and impact what you say in response to the patient. But if you come to the hospital or to the clinic or to that patient encounter, and you have a tendency to think that you already know what the right answer is, or if you're like most of us, and there are situations where you have decided already what the person's going to say and what your opinion is of it, that's going to get in the way of an effective doctor-patient relationship. So we're increasingly putting emphasis on those skill sets in the Geisel School of Medicine so that our students are not just technically very, very solid, but on the interpersonal communication side, which is equally important to the patient, that we're setting the standard. At a time when there is considerable pressure to see more patients more quickly, it's absolutely vital to recognize that every patient is an individual, and start with every encounter with a clean slate, so to speak. You are 100% my focus for the time of our visit. I'm going to be present. I'm going to do everything I can to not be distracted by the kinds of distractions that can get in the way of your being present with that patient. You want to be as aware as you can be about the patient's background, their socioeconomic status, their cultural heritage, because that is the context that they're bringing to the conversation, and to the extent that you can live inside of that context. In other words, if you can begin to see their story through the lens that they bring, a lens being another word for a context, through the perspective that they bring, that's only going to improve your effectiveness in synthesizing their complaints, their needs, their diagnosis, their treatment, and again, these are skills that more than ever need to be emphasized. I would say that the time constraints are real. We clearly feel them here at the medical center. One of the ways to deal effectively with those time constraints, we have physicians who say, I'm on average can only spend 10 minutes with the patient, is to recognize that patient care today can be very effectively provided by a team. And so if you can incorporate the other members of the team, perhaps the nurse, the other clinicians that are involved in the care, the students. The students are absolutely terrific at spending time with families. This is another way of really building the doctor-patient relationship, and it is a relationship. It's a relationship that is grounded most fundamentally in trust and commitment. If your patient is vital that the patient's experience, you as their physician, as an agent of trust, and as a person who is committed to their well-being. That's a lot easier said than done. As you know, the doctor-patient relationship is being pulled apart, so to speak, being, you could say, jeopardized, being constrained by market forces, by legal forces, if you will. But I would say, that if you look at the doctor-patient relationship and what needs to govern it most fundamentally, it cannot be the marketplace. You can't ignore the marketplace. It cannot be the legal system. It has to be a covenant that is a covenant between the physician and the patient. And again, that covenant is anchored most fundamentally in two things: trust and commitment. We've made a commitment to design a curriculum a 4-year experience for our medical students that produces physician leaders. There's little doubt that we're producing top-notch physicians. You look at the performance of the Geisel medical students on standard exams, board scores, the kind of residencies that they match in. We're right up there with the very best institutions. So that the development of an individual who has doctoring skills, if you will, who can diagnose and treat, we're good at that. We don't think that's sufficient today. We think that our students should also be skilled in other, again, building on what we talked about before, in other conversational domains. So as we look at the biggest issues that we think are going on in healthcare, we've parsed them out in 3 or 4 areas, and I'd be the first to say that there are a huge number of big challenges. But we're very committed here at Dartmouth to be leaders in fixing the delivery of healthcare, and we would say that that's an enormously daunting task. But to just put a little bit more specificity on that, we think that we need to rethink where patients are treated. We think a lot more patients can be treated out of the hospital. We think there's going to be treatment in distant locations, which is enabled today by some of the technological advances. We think that we need to do a much better job with access, but not every patient needs to access the academic medical center. They can access other members of the tiered network so that we can begin to provide a structure that allows us to care for an entire population of many hundreds of thousands of patients. We think another area which we are very committed to putting a stake in the ground, so to speak, is the whole area of global health equity. Dartmouth is blessed in that we have a number of very effective relationships with countries like Peru and Tanzania, a growing one in Rwanda, a growing one in China, a very inspiring one in Kosovo, and we want our students to have experiences there. So these are examples of providing student with a different set of leadership skills, be it in the science of healthcare delivery or the science of global health, which, if they become proficient in, allows them to be effective in those domains as physicians. And we, at the most fundamental level, believe it is our responsibility to end up with a 4-year, I hate to say the word product, but we want our graduates at the end of 4 years to not just be great doctors, but to be able to make a difference in the big areas where healthcare reform is absolutely most necessary. And so in order to do that, we have to have a much stronger 4-year longitudinal experience in leadership, and we're beginning to integrate that into the curriculum. We don't want it to be a 2-week isolated series of lectures on strategy and operations and marketing, although those things are important. We want it to be a full 4-year longitudinal experience, which begins with leading in here, because we think you got to be solid and square in here before you can be effective out here. So that's a very important part of the future that we've made a commitment to. We believe that if we're going to produce these physician leaders in global health or delivery science or innovation that you can't learn that out of a book. In fact, one of the concerns that I have about the current ways that leaders and leadership are taught is they tend to be taught based on a set of theories and concepts that are very, very well articulated in many books and articles. And I'd be the first to say that you know, those are very important, and I've written a few of them myself. But assuming that being an effective leader can occur just by reading a book would be assuming that you could ride a bike by just reading a manual, or that you could be a top-notch physician just by reviewing a set of PowerPoints or a set of lectures. Those are important, but you got to get on the ground and experience it as lived. And there's no better way to do that than to go to a Peru or a Rwanda or a Tanzania, or right here in this country at some of the Native American reservations where Dartmouth has a very strong relationship, and you know, our students who do projects and capstones at you know, here, whether it's in Minnesota or Arizona, that have an enormously positive experience. So you got to get on the ground. You got to experience it first person. Remember, a lecture is third person, and it's got to be as lived. And when you interact with people from different cultures, different countries, different backgrounds, different languages, different challenges, there is the opportunity to become immersed, or at least begin to see the world through their lens. And without that, the breakthrough in caring is much less likely to occur. Our students go to places where people make $100 a year, and they immerse themselves in those communities and work with those individuals and listen to their stories, and that's when the breakthrough occurs. That's when they are able to experience exactly what the other person is dealing with, and that's what sort of grabs them by the jersey and says, I have got to make a difference here. And it's very powerful.